Thank you very much, dear Presidents, for the kind invitation. This afternoon, in the next 20 minutes, I will speak to you about a game. It's just a very easygoing presentation, nothing heavy, about an application, basically, which is a game that you can download in every device that was generated, you know, by chance, by our, at the beginning it was just for fun among us, generated by our passion for dermoscopy, by our everyday practice, and now it's out there. You can download it in every iOS or Windows smartphone. And this is basically the motto that we selected, because this describes, in my view, accurately what this game is. First of all, it's a game, so having fun is the main, the main goal. But also, instead of playing any other kind of game, if you are a dermatologist or a GP dealing with dermatology a little bit, maybe you can select this because it might be really useful for your training, especially for training what we used to call the blink diagnosis. And I will try to show you immediately what we mean when we say blink diagnosis in dermoscopy. It's a very common term. So first of all, a short introduction. You know that dermoscopy is becoming more and more popular. We see it everywhere. I mean, in all congresses, in all several courses in different countries, very popular. Young people especially are passionate to learn dermoscopy. And why? I mean, if you ever consider why. So in my view, there are three reasons why dermoscopy is becoming more and more popular. And this is the first one. It's simple. Dermoscopy is addictive somehow. And especially if you apply it from the very first day of your training, then, I mean, you cannot do without dermoscopy. It's really an addiction. We like it very much, we as doctors. And you know, not only we, also patients like it very much. No, I'm speaking seriously, they love it. Maybe, I guess that maybe they love it because, no, I mean, why? Maybe they love it because if you use your dermatoscope, you have to come close to the patient. Maybe you touch a little bit, and this gives the, the perception that you're really, I don't know, but many of them ask for it. So, doctor, I came here for dermoscopy. So we love it, and patients love it. And of course, why do we love it? Clearly, there is a reason why. And the reason is that it reveals, it brings to our eye structures that are completely invisible without our dermatoscope. It's not a magnifying glass. It reveals structures that you cannot see at all if you don't use your dermatoscope, as this ink spot lentigo. But today, we use dermoscopy for everything, not only for skin tumors. For example, this is, who could imagine 10 or 20 years ago that we will not need anymore the scrapping test for diagnosing scabies. Of course, we don't need it anymore because we see the mite live. We see it live. It's very easy. It's very, the animal. We can see the animal. This is today. This is not the future. This is what we are doing today. And we can also see the barrow. We have also numbers for it, if you like numbers. So evidence demonstrating that the accuracy of dermoscopy is higher, at least equal or higher from the scrapping test for diagnosing scabies. We use it also, and this is the so-called jet with contrail, the typical dermoscopic pattern of scabies. And we also use it in inflammatory diseases. For example, we know today that WCAMS3 of lichen planus is not present only in mucosal lesions, as textbooks are suggesting. It's present in every skin lesion, but in order to see it, you have to apply your dermatoscope, and it's there. This is the WCAMS3 of lichen planus present in every plaque of lichen on the skin, okay? So we use it for everything. It's more or less like our stethoscope. We use it in several indications today. This was the first reason. The second reason, which is very important, is that dermoscopy is easy to apply. And this is really important. The dermatoscope is small, like this, even smaller than this. You have it in your pocket, and you can use it very fast, very quickly to scan many lesions. And this is very important in comparison, for example, with newer techniques like confocal microscopy, like OCT, and so on and so on. There is always this discussion that a technology has to be efficient, but it also has to be easily applicable. If I need a huge amount of money or a huge amount of time to apply something, then it restricts the applicability in the clinical setting. Dermoscopy is associated with the advantage of being relatively cheap, inexpensive, and fast to use. Okay, so even if you have to scan, many lesions, it's just look. That's it. It's a matter of, I don't know, 1 minute, 2 minutes, 3. minutes, even to scan a big number of lesions. This is what we're doing every day. So the second reason, and we have numbers that the time that dermoscopy, the additional time that dermoscopy requires is on average not more than 3 minutes comparing to if you don't use it. So the second reason is that dermoscopy is easy to apply. And the third reason, of course, very important, because without this, the two previous reasons would be meaningless, is that dermoscopy is really useful. Why it's useful? Mainly for several reasons, but mainly because it allows us to recognize melanoma and skin cancer earlier. It allows us to recognize melanoma before it becomes clinically evident. Look, this is a melanoma of, I don't know, 2-3 millimeters, so definitely negative from the ABCD clinical rule, but dermoscopically it's not so difficult to recognize that this is not a benign lesion, even without a lot of experience, okay? With simple words, dermoscopy reveals us the physical, the natural asymmetry of melanoma much before it becomes clinically evident. And of course, you know very well how important this is for the prognosis of our patients. Okay, of course, here we also have numbers at the highest possible level of evidence, meta-analysis, suggesting that, not suggesting, demonstrating that dermoscopy increases the diagnostic accuracy of clinicians. Now, okay, dermoscopy is nice, dermoscopy is funny, dermoscopy is useful. The problem might be how can we learn it? And this is not a problem, of course, for a 25-year-old guy who is just beginning the residency, but maybe for somebody who is not in a phase of his or her life for studying and learning new things, then maybe it's not, I mean, he's not very positive to learn all these new structures, all these new terms that we use in dermoscopy, because unfortunately in dermoscopy we use different terms from the ones we learned in dermatology. We don't use the terms papule, macule, and so we have different alphabets. And it's true, I mean, we have to learn the alphabet, otherwise we cannot communicate to each other. Okay. And then, after the alphabet, maybe we have to learn and apply the algorithms. Okay, what do you think? Let's see about the algorithm something. So this was the first algorithm ever described in dermoscopy, the so-called ABCD described by Willi Stoltz. And this is an algorithm suggesting that we have to assess 4 or 5 different, different structures in 2 axes and then do some complicated calculations. And of course, nobody applies such an algorithm in everyday practice, because you can imagine that we need 5 minutes per lesion, so 2 hours per patient doesn't really work from a practical point of view. And maybe this is why Scott, a few years later, decided to simplify it a little bit, restricting the structures only to 11, but still 11 are too many to apply to assess in its lesion. And maybe this is why JP a little bit later tried to restrict them to 7, only 7. But still, let me tell you, nobody of us uses algorithms in everyday life when we assess lesions, because they are not practical you cannot do it in your everyday life. We don't do it. They are maybe very useful for teaching purposes, but not for practice. In practice, we use an algorithm described many, many years earlier, but thousands of years earlier, by a Greek guy. I mean, I don't know if you know this guy. If you know the story, Archimedes, Eureka, when he got in his bath, he immediately realized in 1 second that the amount of water going out is the same with the mass of his body, Eureka. So in 1 millisecond, he realized the theory, and this is how this word came out, Eureka. And this is, by the way, the approach we use in the real life. We immediately recognize patterns that are here, that are stored in our brain. This is how it is. So in fact, when I see a lesion like this, I don't analyze too much. No, I don't analyze at all. Immediately something tells me that this is not good. This is how it works in real life. And in fact, it should be like this, because how does our brain work? I will show you with an example. What did you see? You saw an elephant. You recognized an elephant. Do you know in how much time? 0.1 millisecond. Obviously, you did not analyze anything. You just recognized in 0.1 milliseconds something that you knew. And imagine, if we have here a very young boy, months old, or girl, months old, never seen an elephant, and we want to teach him or her how an elephant looks like. What are we going to do? We are going to start saying, okay, if you see 2 big feet, and 2 more big feet, and 2 big ears, and 1 big tail, and 1 big nose, then Remember that this should correspond to an elephant. No, we don't do it, and it would never work. What do we do? And you know, the criteria, if they're not combined correctly, do not correspond to an elephant. So it's not criteria. What do we do, in fact? We say to the child, look, this is an elephant. Look, this is an elephant. Look, 3 times, 4 times, I don't know, 7, 10, 20, and that's it. Afterwards, the child is able to recognize the elephant, the child is able to recognize the early elephant, even the atypical elephant. This is how it goes. Yeah, but this is how it goes in real life. This is the procedure we all went through. And this is the procedure the children are going through in order to recognize patterns. So our brain recognizes patterns. Our brain does not analyze patterns, okay? Recognizes. Now, the question is, how many patterns should we learn? 1,000, as many as the dermatologic diseases. Well, okay, not so many, let me tell you, in order to do the vast majority of our everyday work. Not so many, like 3 or 4. For example, we have to learn the patterns of nevi. Of course, nevus is the most common benign tumor. And we know there are 4 main patterns, not so many, 4 main patterns. So the globular, which is the predominant pattern in children, the reticular, which is the predominant pattern in adults, then the starburst, which is the pattern of Spitz nevi, and then the homogeneous or structureless, which is the pattern of blue nevi. 4 patterns. That's it, more or less. And especially speaking about the reticular nevi, which are the most common ones, the ones that we all have as adults, there are some patterns of pigment distribution that we have, we have to memorize. And then what we have to do is to look many times without dermatoscope at the many phases of this benign tumor. I cannot teach you anymore. I cannot teach to anybody anymore where the regularity stops and the irregularity begins. It's not possible to be taught. The only way to acquire this knowledge is by practicing yourself, by looking at the benign moles, not at the malignant ones. Okay, so at nevi, many nevi. The more nevi you see, the more confident you feel that all these are aspects of a benign tumor, of a nevus. Okay? So nevus is the first pattern that we have to learn. The second one is seborrheic keratosis. And especially for SEPGA, we were lucky. Dermoscopy helps us a lot. There are very nice dermoscopic criteria for SEPGA. For example, the so-called milia that are very shiny, like stars in the sky. These whitish, shiny structures. Milia like cysts, we call them in dermoscopy. And they are very characteristic for SEPGA. And then we have the comidos, the comido-like openings that are also very characteristic for seborrheic keratosis. And then we have the brain, the so-called brain-like appearance, which is very specific for seborrheic keratosis, especially when located on the face. And finally, we have the fingerprint pattern, which corresponds mainly to the solar lentigo, which is considered today a subtype of seborrheic keratosis. That's it again. 4 patterns also for SEPGA. And then a third one, BCC. So we spoke nevi, SEPGAs. Now, BCC, the 3 pattern. We have the arborizing vessels of basal cell carcinoma that are a little bit like, have a tree-like appearance. So stem vessels branching to capillaries, to thinner capillaries, and finally to even thinner capillaries, and so on. And the same tree pattern in basal cell carcinoma might correspond also to pigmented structures that look like leaves, and we call them then leaf-like areas. So tree-like pattern of basal cell carcinoma. And this was number 3, and these are pictures of these leaf-like structures. And we have one more, angiomas, that are typified by the so-called lacunar pattern, multiple globular, reddish, roundish structures. And that's it, more or less. 4 patterns: nevi, SEPGAs, BCC, and lacunas. And with this, we can do the majority, and angiomas, sorry, and with this, we can do 80% of our everyday work. Of course, there is one more that we have to keep in mind, and this is the pattern that does not follow any logic, that does not follow any rule. And this is the crazy pattern, the pattern of melanoma, which, as I told you, is an asymmetric tumor morphologically from the very beginning, even if we cannot recognize it. But with the dermoscopy, we can recognize it earlier that this is an asymmetric tumor. And here we have no rule. This is the main asymmetry, is the main clue to recognize melanoma. Melanoma is not a symmetric lesion. Of course, we do have many melanoma-specific criteria. I cannot go through them analytically now. I will just show you a couple of images to understand that the main rule is symmetry versus asymmetry. So melanoma is on the left because the network here is atypical. And when we say atypical network, we mean more than one types of network within the same lesion, in contrast to the typical, to the symmetric network of nevus. Regression is a very important criterion for melanoma, especially in situ tumors. It's a very frequent criterion. Again, here, in melanoma, regression does not follow any rule. For example, the top half of the lesion is regressed. Also, nevi might regress, might involute, but they follow, I mean, the regression follows a logic. So it might be from the center to the periphery, okay, or the opposite, from the periphery to the center, the so-called Saturninization, Saturn phenomenon, okay? But there is a rule, huh? There is some procedure that nevi follow. In contrast, melanoma, no, melanoma regresses in a way which does not follow any rule, okay? The same is for dots and globules that are regularly distributed in nevi, irregularly distributed in melanomas. For example, this part of the lesion, we have not at all globules, while here we have many. The same for blotch, which is centrally located in hyperpigmented nevi, eccentrically located in melanoma, and the same for streaks, which are symmetrically distributed in nevi, in spitz nevi, and asymmetrically distributed in melanoma. For example, in the upper part of the lesion, we don't have streaks at all, okay? Again, symmetry versus asymmetry. This is the main logic. And of course, we have two additional criteria of melanoma that we don't want to see them because they correspond in invasive advanced tumors. When we see a blue color, blue-white veil, then this by definition is an invasive tumor. And also this is the case with atypical vessels. They are usually present in invasive tumors. Okay, and that's it more or less. And with this knowledge that I was speaking about the last minutes, we can do, let's say, 80 or 85% of our everyday practice, especially melanoma. In the majority of the cases, is easy to diagnose. Unfortunately, sometimes because the patient comes in a stage where diagnosis is not a problem. There are other problems at this stage, of course, but not diagnosis. Okay, this melanoma is easy to diagnose. Even this melanoma is very easy to diagnose, especially with dermoscopy. Nobody will assess this lesion as benign, so diagnosis here is not really the problem. And for the last part of the last minutes of my talk, I would like to ask your participation. Let's see a few cases together, and we will finish with a couple of cases from the app, from the game. Okay, let's move in our everyday practice, but we don't have patients here, so don't worry. You might be wrong, no problem at all. Just speak loudly to help me go on with this presentation. So the first tumor that we see together, this is the clinical aspect, this is dermoscopy. What do you think based on what we said? Exactly, this is an angioma because of the multiple lacunas, although clinically it was quite ugly. Okay, excellent. These are the cases we see every day. Clinical aspect, dermoscopy. What do you think? It's okay, just the nevus. Excellent. Okay. Next one. What about this one? Clinically, might be SEPK or what? Or a melanoma. Okay. What is it dermoscopically? A SEPK because of the multiple milia. Okay. This is our everyday life. And this, of course, is what? This is a melanoma. Okay, in any of these cases, I guess that you did not do any pattern analysis. In all of these cases, you just recognized patterns that you know that are stored in your brain. And now we'll do together another game, but it's only a game. It's going to be very quick. I will show you 10 cases, but you will see the cases only for 1 second each. And you will just tell me if it's good or bad, but immediately. Good, bad. That's it. And let's see how you're gonna perform. Okay, this is the first one. So let's begin. Good or bad? You know what? You were correct in all cases. And you were correct in all cases. You saw difficult lesions, some of them, for 1 millisecond, and you were able to recognize them. Believe me, it's not easy at all to recognize a melanoma like this one. This is not an easy to recognize melanoma. I'm speaking seriously. And also, this one is not this one also, but especially this one is not an easy to recognize melanoma. And you all say bad immediately. Based on what? On an immediate recognition of something that I showed you a few minutes ago, which is symmetry versus asymmetry. And this is the truth. This is how our mind really works in our everyday life. And you know what? My last point, when morphology is not enough, when you don't have your blink diagnosis in 1 millisecond, because it doesn't work 100% of the cases, it works 80% of the cases, or I don't know. Sometimes it does not work. Believe me, in these cases, even if you try to apply any kind of analytic approach of the morphology, the most possible is that still you will not be able to assess the lesion as benign or malignant. Because if I try to apply an algorithm here, I will block again, because I can't say if it's chaotic or not chaotic. If I knew the answer to this, I would have immediately replied as good or bad. Okay? So when morphology is not enough, then the most reasonable approach is to apply rules in order not to miss melanoma, which are not based on morphology anymore, but they are based on the overall clinical concept and on the common sense. Okay? Of course, I don't have the time now to analyze these rules. Okay, so that was it. The very last part is just to show you the outface of the game. This is what you're going to see if you download it. So it's really as a usual game with multiple levels. And then you open a level and you have sessions. And then you open a session, and it's like this. I will show you. Let's play a little bit virtually the very first level. So you see the image, okay? Here there is time. You have only 8 seconds, because it's like the blink approach. And then you have to press answer, and then you have 8 predefined answers, which are always the same and always on the same position. This is important because after a few cases, you know where is melanoma, where is nevus, and so on, so you can do faster. Okay? So for example, here, what's our answer? BCC, excellent. Then if you get the correct answer, it's green. If you get the wrong answer, it's red. This was correct. What's that one? Excellent. Okay, so again, it's correct. What's that one? Angioma. Of course, this is level 1, Not everything is so easy. Okay. And then what about this one? It's a nevus, excellent. And this one? A beautiful BCC, excellent. Good. What about this one? This is a melanoma, and this one is again a nevus, and that's it, more or less. We succeeded, and we go to the next level. And of course, there is also a ranking for each country, a ranking also for all the world, and you can compete with your colleagues, and of course there's a lot of fun, but it's also useful because you exercise the blink approach that is very useful in everyday practice. And my very last slide is that, if you don't know it, we have the honor to organize the next World Congress of Dermoscopy. This is an event taking place every 3 years. The last one was last year in Vienna. The next one is in 2018 in Thessaloniki. You are all very welcome. And there, by the way, the registration, I had the comment that the registration is already open, although we are 2 years earlier, because you know that in Greece we were very well organized generally. Oh, why are you laughing? At least 2 years in advance we organize everything. So thank you very much for your attention.